So we would like to begin the next session, so which would be pros and cons. So it will be an interesting session of prophylactic cerclage indication, types and conundrums. Pro would be supported by Dr. Vairamala madam, and con would be supported by Dr. Palaniyappan sir. For this session, I would like to invite the chairpersons, Dr. Aruna Ashok madam, who is the clinical director of A4 Fertility, needs no introduction, and Dr. Balakumari madam. Dr. Balakumari madam, she is a part of A4. She is a senior obstetrician and gynecologist, first graduate from her village, undergraduation from Stanley, obtained 3 gold medals in MBBS, and she is a senior consultant at A4 KS Fertility Hospitals, Velachery. She is not a new member at all. She has been a part of A4 for the last 6 months, and she is so supportive to her junior colleagues. Thank you so much, madam. I would like the chairpersons to please introduce the speakers. So it would be a pros and cons sessions of prophylactic cerclage.
So we welcome Dr. Vairamala, fertility obstetrics and consultant. She is associate professor in OBG department in Government Medical College and Hospital Tiruvallur. She has entered into government service in 2001. And she did her undergraduation from Madras Medical College and post-graduation from Coimbatore Medical College. She has got the Best Doctor Award from OBG department in August. KMC winner of IMS. She is Best Doctor Award and also a winner of IMS quiz. She is a trainer in emergency obstetrics drill every year at KMC. Laparoscopic. She has also done a laparoscopic training, and we welcome her to deliver for the pro of cerclage. And Dr. Palaniyappan.
Thank you, madam. Good morning to one and all here. It's a privilege for me to address this august audience gathering today, the mixed population of my senior colleagues, my colleagues and my students as well. Though this is an age-old topic of a cervical encirclage, still the debate goes on whether to put cervical encirclage to apply or not to, especially in the context of IVF patients. So before that, I would go through a glimpse of pro for cervical encirclage, prophylactic cervical encirclage in IVF patients. So this is the era of IVF FOGCE, where it presents unique challenges for reproductive outcomes. The prophylactic cerclage has emerged as a potential solution to improve the pregnancy till term, to prolong the gestational age, and to reduce the risk of preterm birth and low birth weight. This presentation will explore the benefits and the considerations of this intervention. Coming to the understanding of cervical encirclage, it's a surgical procedure to reinforce the cervix during pregnancy. It involves placing a stitch around the cervix to prevent the premature dilatation and labor. This intervention aims to support the cervix and reduce the risk of miscarriage and preterm birth. Prophylactic cervical encirclage is applied to asymptomatic pregnant women. It's a planned procedure. It is done at around 13 to 14 weeks after the NT scan to ensure fetal viability and after ruling out the aneuploidy screen of the lethal anomalies. Several studies have shown that there is significant increase in cervical length following the insertion of cerclage. The pathophysiology. As you all know, IVF pregnancies have high twinning rates. So they are prone for preterm labor due to uterine overdistension and mechanical stretching. And there is also dysregulation of local immune environment, which is also implicated in this. In successful IVF pregnancies, post-correction of anatomic abnormalities, the reinforcement is all the more important. So the rationale for prophylactic encirclage. Following the prophylactic encirclage, there are also pre-pregnancy reports of prophylactic encirclage, which improves the implantation rate, and there is reduced rate of cervical insufficiency. By providing structural support to the cervix, this intervention may enhance the likelihood of successful full-term pregnancy in this patient population. These women are high risk post-IVF. So cerclage also enhances the immunological barrier by improving the retention of mucus plug. The inherent preterm neonatal complications such as the respiratory distress syndrome, necrotizing enterocolitis, IVH and cerebral palsy are averted since there is prolongation of gestational age till term. The average number of days spent in NICU is also reduced, so indirectly it reduces the economic burden of the patient as well. Also, there is reduction in local levels of pro-inflammatory cytokines in patients with cervical insufficiency. There is estimated high rise of interleukins, human necrosis factors and MCP in the cervicovaginal fluid in patients with having cervical insufficiency. And all the more important is the psychological reassurance to the patient. When you apply a stitch cervical encirclage in such high-risk women post IVF FOGCE, they have a psychological reassurance and they avoid the bed rest and they can carry on their day-to-day activities. In turn, they feel normal about themselves to carry out their activities and they go to job. So there is an immense factor in that. There are few case reports where pre-pregnancy cervical encirclage was done even before blastocyst transfer to avoid complications of fetal loss, which needs more evaluation and studies. So in a nutshell, this prolonging gestation till steroid therapy is given if PTL, that is preterm labor or PROM occurs, and it avoids emergency or rescue encirclage, which is of no value. There is a low incidence of intra-amniotic infection when prophylactic cervical encirclage is applied than the emergency or rescue encirclage, which has a high incidence of PROM and chorioamnionitis leading to preterm loss. It allows free activities of patients. It reduces the medical and economic burden. Medical is prolonged intake of medicines or this progestrogens or the supportive treatment. Potential benefit of this cerclage placement is that it may also help prevent the mechanical stress-induced release of pro-inflammatory cytokines. In patients who have not undergone prophylactic cervical encirclage, we offer the TVS ultrasound from 14th week. This is a cervical length screening strategy in which if the cervical length is more than 3 cm, we repeat every 2 weeks until 23 weeks the follow-up. If the cervical length is between 2.5 to 2.9 centimeters, it is to be repeated every week till 23 weeks. If the cervical length is less than 2.5 centimeter at 24 weeks, we offer cervical encirclage. In measuring cervical encirclage, we should understand that the cervical modeling in pregnancy is dynamic, and hence the 3 measurements are made over 5-minute period at each examination. So these are the various techniques in cervical encirclage. First, the transvaginal encirclage, where a purse string suture is placed at the cervical isthmus junction without bladder mobilization, that is McDonald's, and you have a high transvaginal encirclage requiring bladder mobilization, that is Shirotkas. A transvaginal purse string suture placed following bladder mobilization to allow insertion above the level of the cardinal ligaments. That is why it's called high transvaginal cerclage. So this is the placement of sutures. The lowermost one is the McDonald cerclage. Next is the Shirotkar following bladder mobilization and by posterior colpotomy. Next is the transabdominal cerclage. This is the left side of the screen shows the cervical stitch procedure, how the purse string is applied, and the knot is placed anteriorly, and when the cervical stitch is complete, on the right side. Transabdominal cerclage is performed via laparotomy or laparoscopy. So whichever way it is applied, the success rate is the same. You place the suture at the cervicoisthmic junction. There is an occlusion encirclage where the external os is occluded by placement of a continuous non-absorbable suture. There is the potential benefit of occlusion encirclage is there is retention of the mucus plug. So this is the transabdominal encirclage where we incise the utrovesical fold of peritoneum and we mobilize the bladder down and place this marceline tape at the upper part of the cervix. This is practiced in previous failed transvaginal encirclage and also in short cervix or when the cervix is inaccessible. This is the comparative picture of the two. So the contraindications to cervical encirclage is when the patient is in active preterm labor, when there is clinical evidence of chorioamnionitis, when there is PPROM, when there is continued vaginal bleeding, or the evidence of fetal compromise, fetal death, or lethal fetal defect. In women with the previous unsuccessful transvaginal encirclage, insertion of transabdominal cerclage may be discussed and considered. Can be performed preconceptually or in early pregnancy. Preconceptual procedures are most effective because it avoids the fetal loss and also not associated with subfertility. So when should the cerclage be removed? Removed before labor, usually between 36 to 37 weeks, or unless birth is by pre-labor cesarean section, in which case suture removal can be delayed until this time. Cerclage should be removed to minimize the potential trauma to the cervix in the patient presents with preterm labor. And a high cervical encirclage usually requires anesthesia for removal. All women with a transabdominal encirclage require birth by cesarean birth. And the disadvantages, even if the baby is death, we have to do a hysterotomy. And sometimes abdominal suture may be left in place following birth for future pregnancies. So the conclusion is, though most obstetricians follow this prophylactic cervical encirclage, despite the absence of a well-defined population for whom this cerclage may benefit, this represents a promising strategy to optimize reproductive outcomes post-IVF FOGCE high-risk women. So by addressing cervical integrity and pregnancy maintenance, it improves live birth rates and reduces the incidence of preterm delivery and low birth weight neonates. Continued research and clinical insights are essential to further elucidate its role in IVF practice. So these are the references. And thank you.
Thank you, Dr. Vairamala.